Good morning. My name is Ashley Weiss. I am a registered nurse currently working at Beckley-Appalachian Regional Hospital within the ER. I have been working there 2.5 years. I am in the bachelor's program right now, about to finish, and in this last semester we have been working on our change project. This change project was simply something that we found within our workplace that we needed to change, or we felt could be better. So within the emergency department, we found that bedside reporting, we have a policy for it now, but very rarely implement. So with this change, we are now implementing bedside reporting at all times of change of shift. The goal in this project was to improve communication regarding care at change of shift. The objective was to implement bedside reporting on all patients in the emergency department at Beckley-Appalachian Regional Hospital through an educational program / resource notebook, which will also be a part of orientation for all new hires. And this is simply meaning, yes, the staff today will be implementing bedside reporting, but with all new hires, we wanted to ensure that the bedside reporting continued. The identification of the problem, we had driving forces and of course restraining forces in any change. The driving forces were coworkers and management / administration's willingness for change. The drive to improve patient safety, staff patient satisfaction, and improve continuity of care. Staff have verbalized problems identified after a change of shift, such as missed medications, intravenous infiltration, patients in pain or soiled, as well as dissatisfied family members that could have been avoided when utilizing bedside reporting. And that is key within the emergency department. Restraining forces, of course, no one likes change. Adoption of a new computer system at the same time this change project began. We, as a hospital, changed our computer system February 1st, 2019. It went live, and it was a hospital-wide project, so of course the whole hospital was in a tizzy. And then we added this change in the emergency department right on April 5th, 2019. This occurred. We went live. So a lot of change at one time. And then another coworker was also facilitating their change project. Another coworker of mine, we work day shift together and we're on the same schedule. So both of us having a change project was a little confusing. The description of the environment, I work at Beckley-Appalachian Regional Hospital in the emergency department. Like stated before, we have 29 beds within the ER. We have 4 floors within the hospital. The 3rd floor has our ICU, which has 11 beds. And then we also have an OR on the 2nd floor. And we do have a psychiatric unit within the hospital as well. There are 3 units within that psychiatric unit. They have adolescents, A unit, which is our middle-aged, and then B unit, which is our older folks. These are some pictures of the ER and outside. This is room 29, one of our trauma code rooms. It has our crash cart here, our defibrillator, and it's one of our bigger rooms. We have 3 total. We have 28, 29, and 16 as our code trauma rooms. This picture right here is a patient being loaded up on our helipad. Woodrow Wilson's baseball field is right behind it. We are sending somebody off to a higher level of care. This picture is coming in from our ambulance bay. 29, the room 29 is right behind where I took this picture. And right across from the wet floor sign is our room 16. It is our other trauma room. And then 28 is right beside where this picture was taken. This picture right here is some of my coworkers and one of the doctors we had, Dr. Harris, who is no longer with us, but in Texas. We're sending a patient off to get some higher level of care. This is our ambulance bay empty, which very rarely occurs. This was about 7 a.m. one morning. And then this is our ambulance bay with multiple ambulances, which is normal for us. Within the ER, I passed out a needs assessment, which was 4 questions. I passed it out to 10 individuals within the ER that day. We had day shift, night shift, and then we had some of our mid shifts working as well. Mid shifts just are 11 to 11, 1 to 1, or 3 to 3. The questionnaire was just 4 questions, really easy. I had them go ahead and fill it out for me and then give it right back to me right after. The first question was, do you participate in bedside reporting each time you hand off or assume care of patients? There were 1 yes out of 10. And once again, we already have a policy for bedside reporting, but we're not implementing it like we should, or at least we weren't until this project occurred. Question number 2, do you feel updating guidelines concerning bedside reporting will promote safety and patient satisfaction in our unit? Of course, all 10 said yes, because they realize that bedside reporting is crucial within the ER that we work in. Question number 3, would you be willing to attend an in-service relating to bedside reporting and its benefits? All 10 said yes. So we're all very driven to make change to improve patient satisfaction and patient safety in our ER. And then number 4 was, would you be willing to serve on a committee? And I had 7 out of the 10 members volunteer to be on my committee. These are some of my committee members, including myself as the change agent right here. Guidelines for bedside reporting. At change of shift, oncoming nurses and offgoing nurses will do bedside reporting. This was a checklist that we kind of gave everybody, and me and myself and the committee members had finalized, just to kind of keep everybody on track on what we needed to discuss at bedside reporting. Of course, patient name, allergies, co-status, checking your vital signs. You need to check your vital signs to ensure that if they are within normal limits, and if they are not, we are already addressing that situation with vasopressors, antihypertensives, etc. IV patency and checking infusions. Obviously make sure your IVs are not infiltrated, because you do not want to realize at 8 p.m. that since 7 p.m. or before, the medicines haven't been going like they should have been. And that just really delayed care, and it's hurting the patient in the end. Pertinent labs and chart checking. We have computers on wheels, to take into each room to ensure we have addressed that low potassium, or we have all of our infusions running like they're supposed to be. If the computer says that you're supposed to have Levophed running at 5 mics a minute, you need to check that and make sure that it is, or it has been titrated appropriately in the computer. Repositioning, talking to your patients. You need to ensure that they have went to the bathroom, or you've assisted them to the bathroom within a timely manner. You've addressed their pain. Ensure that they know what's going on. That is the biggest complaint in the ER we have. Wondering what is going on, why I haven't seen anybody in an hour, what are we waiting on? This is the time that would be great to do so, because the offgoing nurse is going to tell the oncoming nurse what we're waiting on. Are we waiting on a bed assignment? Are we waiting on the rest of our labs to be coming through? This is when you tell the patient and the family, so they're not wondering what they're waiting on. Safety precautions, obviously make sure your call light's in reach. Make sure if you have a seizure precautions patient that you have all the seizure precautions set up, the bed rails are, cushioned, everything. The exceptions for bedside reporting, things that need to be discussed in private. Obviously, if you've had a patient that has been raped, you're not going to discuss that right at the bedside. Or if there's possible neglect in the home with the child and the parents are right there, you do not want to discuss that right there at the bedside either. You can discuss that behind the nurse's desk. If the patient is finally asleep after you have relieved their pain, or like I had stated before, we do have a psychiatric unit, and most patients do come through the ER first. So if you have just chemically restrained them or physically restrained them, you do not have to have bedside reporting right there. You can go ahead and do the reporting behind the desk, but make sure you check on your patient right after. This is just simply to avoid agitating the patient any further. We went live April 5th, 2019. Of course, in the first couple weeks, we did have incidents where nurses did not perform bedside reporting, and I think that was a lot of just all the change at one time. But quickly, we fixed it right up, and everybody was loving bedside reporting after that. What worked well and what didn't work well. Staff and management administration excited and motivated for this change. The change of shift went very smoothly, and nurses seemed to be less stressed after accomplishing bedside reporting, because by 7:30, everything was done. You knew your patients were comfortable, you knew everything that were going on with your patients, and you could start your shift appropriately right after. The guidelines were set by committee members and change leader easily, and staff appreciated the guidelines. It was an easy checklist to go by, and quickly we got comfortable with it. The patients and families seemed to enjoy the interaction because you not only had one nurse but two nurses right there at the bedside to communicate with you, which they loved. Some staff was very hesitant for a change due to the adoption of the new computer system also occurring in the emergency department. Like I said earlier, a lot of change at once, nobody enjoys, but it worked. Some staff had difficulty with the addition of bedside reporting simply because no one likes change, but we did make the change and everybody loved it. So in closing, to do what nobody else will do, a way that nobody else can do, in spite of all we go through, that is to be a nurse.